Vidyo. We're excited to be joined today by two of our partners, TytoCare and Ochsner Health. Ochsner is a national leader in medical research with a mission to serve, heal, lead, educate, and innovate. Our partnership with TytoCare provides a simple, easy-to-use solution that enables practitioners to give an advanced level of video-based remote examination. I'm really excited today to be joined by our co-presenters, Jennifer Humbert, David Bardan, and Dr. David Houghton. Jennifer has been very instrumental in the development of new telehealth programs in acute, ambulatory, and direct-to-consumer spaces. As the Assistant Vice President of Telemedicine, she drives innovations in partnership with service line partners and virtual inpatient monitoring areas. Dr. David Houghton is a neurologist and chair of telemedicine at Ochsner Health. David's publications have appeared in peer-reviewed journals, an online medical text, and a patient resource from the National Parkinson Foundation. David Bardan has over 7 years of experience within the healthcare space, securing and building partnerships with leading healthcare institutions. The goal for today's webinar will be to showcase the virtual care strategies that Ochsner Health has employed during the COVID-19 pandemic. David Bardan, I'll now turn it over to you.
Great, thank you, Charles. So hi, everybody. Great to meet you all. My name is David Bardan. I lead enterprise solutions here at TytoCare. I've been with the company now for about 4 years, really ever since our company began to commercialize our products in North America. If you would like to go to the next slide. I'm really excited to talk to you all about today of how we've really married up the best of both worlds between TytoCare and Vidyo. Before we get there, I'm going to just give you a little bit of context on who we are as a company and the types of products that we ultimately offer into the marketplace. So TytoCare actually began back in 2012 out of Israel. It was actually a company founded by our CEO and founder, Dedi Gilad, who was frequently in and out of the care setting and ultimately determined that there had to have been a better way to potentially do some of these type of acute type of care that normally would be treated in an urgent care or primary care type of setting. So with that in mind, he effectively, Charles, can you hear me okay? I'm noticing a few folks are having a few audio issues.
Yes, we can hear you.
Okay, excellent. So with that in mind, he set forth and began developing our product, Tyto, and spent about 4 years in the development road cycle to build out the product that we have in the marketplace today. We've attained FDA clearance in 2016 and began commercializing thereafter. Shortly around that period is when I joined, and we've actually had the fortune of working now with over 100 major health system organizations across the U.S., and we also are a global brand, having both the CE Mark, Health Canada, among other regulatory approvals, allowing us to work across the entire landscape of the world. If you'd like to go to the next slide. Tyto is unique in that it has an all-in-one aspect to it. So it's the industry's first all-in-one medical device that pairs with a virtual exam. As you can see, the base unit there in the image effectively has a digital LCD touchscreen on the front end. And on the back end, it has a proprietary ring connector that allows you to plug in a series of different adapters. For example, like our stethoscope adapter, which can do heart, lung, gastrointestinal sounds. We have the otoscope adapter, which allows you to do ear exams. It is a unique otoscope as it does have a flexible tip, very easy to navigate into your own ear or your child's ear. It also does come with disposable speculums, both in the child and adult length. We also have a tongue depressor that effectively depresses the tongue, also comes in both child and adult length. And on the back end, in addition to that ring connector, we do have a built-in high-definition exam camera that can do external imaging. We do have LED lights on both the left and the right-hand side of that camera to give you optimal lighting. And lastly, we have a built-in IR thermometer for temperature down below. So as you can see, we have an all-in-one kit. We do also have other peripherals that we can plug in, play into the kit. For example, blood pressures, pulse oximeters, and weight scales. If you'd like to go to the next slide. These are the different variations of our products. We have our Tyto Home product, which can reside in the home. Today, our Vidyo and Tyto integration does not support the integration. However, what it does support is our usage of our professional suite of products, which is our professional-grade version of our Tyto Home, the Tyto Pro, as well as the Tyto Clinic, which has really been quite popular as a replacement to most standard telehealth carts. It's about a fraction of the size, about the size of a laptop, and can be bolted down, has a lockable drawer. It's an iPad that can ultimately run, in this case, the Vidyo Connect software pairing with our solution. So I'm sure a lot of you are probably wondering how this works. So if you'd like to go to the next slide, Charles. I'm going to just give you a brief understanding of how we've kind of basically taken our best-in-class all-in-one medical device and paired it with, in this case, a best-in-class video solution in Vidyo Connect. So as you can see, you're marrying up the best of both worlds. You're running Vidyo Connect, where you would typically run it, potentially at a point-of-care location, and you'd basically have, in this case, the TytoPro present next to that experience and basically have the opportunity now to bring this diagnostic capability into the session, connecting into the experience, allowing the provider on the other end to remotely examine the patient wherever they may be. To get into more of the specifics of how this experience actually works, if you go to the next slide, Charles, we actually have a breakout of exactly how this looks. So as you likely went into your settings feature in your top right to disable notifications prior to this beginning, you'll actually see that there's also an integrations button that exists. Within that integrations button, if it's enabled for your system, there's the ability for you to actually join or include the Tyto device, which basically prompts you to scan a QR barcode. Once you've scanned the QR barcode, it's a one-time pairing process with that device. It allows you thereafter to basically bring forth that device whenever the provider decides to connect into it. If the provider decides to connect into it, a small exam frame, iframe, will pop up. That iframe is adjustable. You can put it onto the screen that you're using to see the patient, or if you're using multiple monitors, you can potentially put that on your secondary screen. So it's really, in this case, marrying up all of the best-in-class features that Vidyo Connect offers and combines it with the experience of Tyto's best-in-class examination platform and its devices that it offers through this experience. If you go to the next slide, Charles, we'll actually highlight, Charles, if you go to the next slide, we'll highlight some of the key value propositions of what our product can offer in this experience. It can improve patient outcomes. Oh, here we are. I think the slide is on the use cases now.
Oh, sorry.
So we'll actually go forth and talk through some of the use cases. It's okay, Charles. You can go to the next slide. I think I've spoken through some of these. There you go. So if you take a look at some of these use cases, I think this is really the star of my particular presentation and what you could potentially offer through this. So I'm sure a lot of you right now are offering various telemedicine capabilities in a number of capacities due to COVID. And so if you start to think about your ability to still maximize the care continuum for patients who potentially need specialty access, for example, with virtual rounding, being able to connect into that particular site with the number of providers at remote locations, specialists, you have it. School-based environments, especially now with schools kicking back off, needing to potentially have this type of equipment to produce top-notch care at those locations, connecting back to your providers. Urgent cares and load balancing, really the remote clinics where you may not have as great of access, inpatient or ED consults, visiting nurses who may be looking to go into the home. If you don't have the flexibility of sending in a physician or a nurse practitioner, potentially having an MA, LVN, someone who may be less clinically trained can go into the home effectively and connect back into an MD, a nurse practitioner, PA. Specialty consults, very prevalent, especially in rural locations, post-op type visits, employer on-site clinics, and even care facilities, especially now with COVID, elderly care sites where you're looking to really reduce the in and out exposure of those respective sites. So with that in mind, I think we can go to the next slide, Charles, and I can wrap up here. I'd like to introduce Jen Humbert and Dr. David Houghton. They're two great individuals who I've had the fortune of working with really now ever since our product began to commercialize here in the U.S. They have been a phenomenal partner in using our products as well as the best-in-class video experience in Vidyo Connect. So I'm going to turn it over to them to really give you more insights on how they've effectively offered our solutions into the marketplace. Go ahead, Dr. Houghton and Jen. Thank you.
Well, thank you, David. This is a terrific opportunity for us to be not only here with you, but also Charles and the teams at both Vidyo and TytoCare. I am Dr. David Houghton. I'm a neurologist by trade, and over the last 4 to 5 years, I've had the unique opportunity to work in our system down in New Orleans, Louisiana, as one of our strategizers with Jen in how we're building our different virtual health solutions. That's expanded everywhere from what we've done in the hospital initially to now direct consumer to back-end digital medicine products. And we're both really happy to be here today to be able to talk with everybody about our experience, not only with COVID, but where we're going and beyond. Jen, would you like to introduce yourself?
Sure. I'm Jen Humbert. I'm the Assistant Vice President in Telemedicine. I have been in telemedicine for the past 8 years and here at Ochsner working on the development team to develop new telehealth solutions and products for the last 6 years. I am a nurse by background, and I believe Dr. Houghton and I are kindred spirits because I am a neuroscience nurse by background, so we have lots to talk about in our off time. So I'm really excited to share some of the things that we've done and we're able to leverage and accelerate some of our strategies through the pandemic.
Charles, if you could go to the next slide, that'll give everybody a snapshot of where we sit down in the Gulf. So it shows all of our partners, there we go, across our region. And it's a unique place where we live, right down at the toe of the Louisiana boot. But you can see that over the last several years, we have worked diligently to try to build partnerships with different hospital systems, different employers, schools and other universities, even payers across the region. So when we realize the different wings of telemedicine that we can provide, whether it be in the hospital, whether it be in the clinic or ambulatory space or post-acute, now at home, we've really got this area covered. And it's allowed us to learn a lot about the growth of telehealth. And I think more importantly, it's allowed us to reach more people in need. On the next slide, this gives a little bit of a snapshot of what our journey has been. So we're not brand new to this game, as many folks in the telehealth field are now. We go back more than a couple of decades with what we were able to build initially. Our first program in store and forward pediatric echocardiography, cutting down on the needs for pediatric cardiologists or the patients, some of the most vulnerable patients, to waste time and effort with windshield time, driving to and from different parts across the Gulf South. More than a decade ago, we launched our first telestroke service, like a lot of large hospital systems dip their toe in the water for the first time with telestroke. And then we really used that experience to help build tele-ICU, telepsychiatry, and other in-hospital and in-clinic models. Since I've been involved with telemedicine, it's been one of our greatest pushes to see what we can expand with those partnerships and also what we could build with direct-to-consumer telehealth, which is really where our relationship with Vidyo and TytoCare has been strengthened. And fortunately, I would argue that it's been the groundwork that we were able to create over the last almost 25 years that allowed us to be prepared for COVID. If you go to the next slide, Jen's going to really explain what our experience has been and how we reacted to some of our environmental factors.
Great. So, you know, as every health system, as we started to begin to prepare for COVID, I think there was an initial response of, is this truly going to happen, and are we going to get hit with a pandemic? And then we quickly shifted into, as a healthcare system, probably one of the strongest tools that we had to combat this was to decrease exposure and decrease spread. And what is the best, you know, what is one of the best ways to do that? And that is great audio video access and assessment of our patients remotely to decrease that exposure, keep our patient, you know, and decrease spread. So we had this moment that said, okay, we need to shine, and we need to probably focus our efforts immediately in 3 areas. So we immediately went to, how do we keep patients in the community? How do we get them screened? How do we get them tested? How do we route them appropriately to virtual care so we can help assess and then keep them out of the healthcare system appropriately to prevent exposure. So we had an entire work group that was focused in our urgent care and primary care space, and immediately started thinking about how we institute protocols for mass deployment. We had our, as Dr. Houghton described, we had our toes in the water in the direct-to-consumer space, but probably not that proliferation across our system. So we took an approach of how do we standardize these, how do we implement and standardize protocols across our system and turn everything on. And a key to that was our clinical criteria. How were we also assisting our patients in clinical criteria to get them to the right place? In the same time, as Chair said, within 24 hours of us focusing in that space, we quickly said, okay, we are going to be able to prevent patients from coming into the system, but our patients are still going to need our care and they're still going to need to come in. So we started immediately running a parallel group that partnered with our emergency and hospital med teams, supported by our ICU, and really started to implement some standardized protocols to implement those same approaches. How do we decrease exposure for our providers and clinicians at all levels, between patients and providers the same, and how do we safely do that and provide access and spread the workloads across our system. And then we also had to also focus on, we currently have a patient population that still needs our help, and how do we continue to help our current population so that they don't get lost in the mix as well. So we really took that three-prong approach to mass produce, deploy across our system in the most standardized way that we possibly could to be able to get this well-needed tool across our system, probably one of the best defenses that we had to help us decrease exposure, proliferated across our system. As we were working that, our governmental partners were stepping up to the plate and helping us along the way as well. And so what we saw was, the expansion, all the barriers that we had prior to COVID, we were starting to see those barriers and pain points from the healthcare system and providers and patients start to crumble, and our the governmental response to expand reimbursement, think about the way that we can help eliminate or facilitate better interstate licensure practices and allow for adequate reimbursement, really helped facilitate and excel all of those efforts forward. Charles, if you want to go to the next slide.
Yes, I'll take this. So this really was, as Jen mentioned, an opportunity for us to look at three major buckets: emergent care, urgent care, and chronic care. But we took that first things first approach. Being down in New Orleans right in the February and March area when we were starting to first see cases on our shores, this also happens at a time that's very important to us down here, which is Mardi Gras. And so I can remember vividly us starting to have these discussions during the Mardi Gras season. And of course, Mardi Gras itself ended up being what is likely to our super spreader event for the Gulf South. And so we were ready to put all of these things in place. And we really, at the outset, were relying on what we already knew best. We had Ochsner Anywhere Care as our urgent care opportunity in the outpatient world. And so we leveraged that up to be able to have more and more patients utilize that type of space for triage and figuring out where to go next for their testing. We have a strong urgent care system as part of our bricks and mortar strategy. So our urgent cares were rapidly converted into testing and triage centers in their own right. And what we used with the Tyto clinics there allowed patients and families and physicians and other providers to be safe, sometimes one wall away from each other, where we were committing ourselves to telemedicine visits there in order to be able to conserve PPE. Our hospital system rapidly worked with industry to build up lab testing, and we recognized that there were opportunities with some other relationships that we already had to expand home testing options as well as delivery, so that, again, everyone was able to really take advantage of the shelter-in-place approach. And so it was this web of opportunity that allowed us to move rapidly initially. Now, on the next slide, Charles, this demonstrates really what our growth was in the ambulatory space. And so this is a busy slide, but bear with me for a minute because it really sort of shows what was happening in the country and the way that certain states and the way that I'm quite proud that our system was able to react. So if you look in the upper left corner, that shows the number of telehealth visits as a percentage of total physician visits during the course of a week. So you can see pre-COVID, these were less than 1%. These were barely ticking across all of the commercial and Medicare Advantage patients that were counted across the country. And then suddenly into March, just after Mardi Gras for us, you can see that at its peak at the end of April, that we were somewhere between 42 or 44% of all of the physician visits in this country were by telemedicine. So just more than 50% still in the bricks and mortar, 40+% in telemedicine. If you look in the lower left corner, you can see how that stacks up by state. You can see where we're circled at 51% for Louisiana. So we were already ahead of the national average. You can see where this was being driven from a national perspective, right? West Coast out in California with what they were dealing with, and mostly in the Northeast with New York, New Jersey, Connecticut. But admittedly, there were a lot of cases coming across the Gulf South and the Southeast. And we were quite proud to be able to lead our region as a state. If you look on the right side, you can see in the green that that's exactly that same time. And so our own health system was at a peak of 63%, and then we're still sitting at around 57% and during that. So we really flipped the script and said we want the majority of all of the physician, these are for traditional clinic visits, we want the majority of the physician and other provider interactions to be via telemedicine. We want our patients to shelter in place, stay at home, allow us to flatten the curve in our community. And so we are quite proud that we were able to pull up our state to be the highest utilizer in the Gulf South and Southeast by our own high 50s, low 60% to get our state up to 51%. But we recognize as this was growing, we were still building the airplane while it was in the air, if you will. And so now Jen, on the next slide, Charles, Jen's going to talk about sort of second thing second. What did we then do to realize how we had opportunities to optimize what we had rolled out so quickly?
Great, yeah. So we did. We had a lot of success. We had our patients and our providers engaged and truly using virtual care and using it appropriately and having a lot of satisfaction with that. But again, you know, in all of this, there were new pain points and new things arising. And with that focus to drive patients to the right level of care, what we were starting to see then in our hospital and inpatient setting and you know, really seeing across our system was we were starting to have some staffing challenges. So we were like, so we took a moment and a pause and said, okay, here's a new pain point. We now have areas that in our inpatient and in our clinic areas that were completely understaffed, specifically in those regions that were the epicenters. So specifically in our New Orleans region, Dr. Houghton had mentioned Mardi Gras. We had a lot of inpatient admissions and increases in cases associated with that. And so we had increased demands to screen and treat, increased hospitalizations, increased exposure, and quarantine staff of our own. So we were starting to have a decrease in our own workforce or quarantine staff that needed to be at home, but then could potentially still provide care from the home setting, and we were having a rising COVID population. In other areas, we were seeing overstaffing. So we were pushing more providers to virtual care. We were asking, you know, there were some of our specialty services that were stepping up and saying, I understand that the hospital medicine service is really taxed, and we're going to jump in and we're going to help them out because that's what we needed to do. And then we were also seeing just that loss in ambulatory volume, even understanding and knowing the amount of virtual volume that we were getting. And at that point, that was the moment where we were really looking at those pain points and working with our operational teams, and I started to see that shift in fixedness thinking. So the operators all of a sudden started to think about telehealth not just as a solution or a way to provide access to patients, but let's take that back a step further in the supply chain, and this can be something that creates efficiency in staffing. And so all of a sudden we were breaking fixedness. This just wasn't an access tool. This was a way for us to do a very interesting, innovative greenbelt exercise in some areas where we were able to load balance staffing, and telehealth really became the equalizer and the facilitator to allow them to do that. And some of the things and the key areas that brought us to that pivotal moment and that second thing second approach was really addressing some of the pain points that not only our providers but all levels of clinicians were having, whether that be physicians, nursing staff at the bedside, social workers, pharmacy. We were able to take that approach and really think about how we leverage our solutions a little bit differently. And so I'll let Dr. Houghton talk about some of the pain points that they were seeing in their roles as we were starting to continue to think creatively to meet our demands.
Charles, next slide, Charles, if you would. So Jen brings up a great point there, which is this balancing that we were able to create as a hospital system. You know, we've got close to 30,000 employees for Ochsner. We're the largest employer in the state, more than 4,000 providers, or physicians, I should say, many other providers of other types. And we had 0 layoffs. We had no salaries get cut. And that took a lot of effort and commitment on the part of an executive team. I can assure everybody here, and some hardworking financial types that are well above my own pay grade. But I'm really proud of the fact that our team, I think, played a significant role in that we were able to utilize our experience in finding care models in different ways to allow people to continue to work at their highest level. And if you go back and you look at a few slides, don't change them, Charles, I'm just referencing. There was a picture of what we were doing in the acute space with a funny-looking gentleman behind a shield. That was me when I did a week in the COVID ICU. And I can assure you, I don't do a whole lot of ICU medicine, but we had an all-hands-on-deck approach, and it allowed us to go into those environments, and I never felt safer. I would joke with people at the time, I felt safer in the COVID ICU with the PPE and the telemedicine than I did going to Home Depot or Lowe's at that time. And so there's been a lot of important shifts that we were really able to capitalize on. On this slide, Charles, if you'll hit the button, it'll bring in a little bit of an animation here. And it indicates on the left side sort of the low-hanging fruit, right? This is what we realize, and I think we as a large system, and I'm sure a lot of the people on the call today have realized the advantages of telehealth for providers particularly, right? So there's increased access and convenience. It's going to reduce the operating costs if you're in a small practice to not need to have all the support. Particularly at this time, a way to recapture lost revenue or even look at new revenue streams. Patients love it, so it's going to increase your engagement, activation, patient satisfaction scores go up, even improving the quality of care. There's great data that indicates that the increased touch points are allowing you to know more about what's happening with a patient's diabetes and hypertension and wound healing. It's preventing readmissions or that first trip to the ER. I think there's some untapped efforts that are being done with provider satisfaction as a whole and what this is doing for burnout to allow people to sort of regain and reclaim control of their own schedules. And lastly, I think some of the most unique benefits are with social determinants of health. But on the right side, this indicates that, again, we can't rest on our laurels. And we were learning that. So we were increasing access and convenience. But now when you don't have a handful of docs doing it, you've got thousands. He and she had a much lower tolerance for tech glitches, so we needed to keep up. And while there may be reducing operating costs that are being realized at one point, someone says, well, what are we going to do to have my medical assistant continue to assist me? So there are expectations that to have continued resources to be able to support in telemedicine. And we had to help with ongoing legislative support to make sure that some of the new payer schemes don't suddenly melt away. And we had to be prepared for uncompensated efforts, communications by docs, right? Patients are activated, so now my chart inbox is blowing up because they're recognizing, hey, these are terrific ways I can continue to reach my doctor. That stuff's not traditionally compensated, and you can see the list go on the right. So the reality is that as we continue to iterate and improve upon the experiences that we've been able to roll out, all of us on the line are recognizing that this is an ongoing process. And Charles, if you'll go to the next slide, I'm going to pass it back to, actually, if you'll fast forward through this one, just click through this. We're now going to tee up a series of slides where we're going to talk about how we approach innovation here at Ochsner. Go ahead, Jen.
Sure. And Charles, I think if you can go ahead and click the slide, we'll animate. So, you know, Back one.
Did not.
Animation free. That's all right. We'll just
okay.
make it. Look at that. You are quick on the draw. Nice job.
So, you know, that's a great segue, Dr. Houghton, and we've talked a lot about addressing the pain points and not resting on our laurels. So I wanted to take a moment just to review briefly on what our approach to innovation is. And you've heard us talk about pain points a lot, and it really does surround, you know, when we think about innovation and we think about the direction that we need to go, we think about our pain points. So the first thing that we think about is, you know, clearly what's the problem statement? And as we're thinking through that problem statement, investing in the voice of the customer. And that voice of the customer are our providers, our end users, our payers, our partners. Our voice of the customer comes from a very global perspective. And we learned, and so we say this a lot, and actually in crisis moment, as we were designing some of our programs to help with those system efficiencies across the board, specifically in a hospital medicine program I'll highlight a little bit later, we missed part of this step, and by missing part of this step, it almost prevented us from being able to implement a very strong backbone program that we have today across our organization. So that investing in your voice of the customer, understanding what those pain points are, and then sticking to your strategy and design concepts as you're thinking through those pain points, clearly identifying what our customers want success to look like, working with them through that, and don't start with the technology. Start with your customer, start with those pain points, understand your strategy, stick to your design principles, the technology will follow. That really fosters and creates that environment for ideation and design. You know, once we set that foundation, the ideas and the design can flow, and the creativity starts to come out. And then we start thinking about, okay, is it feasible and desirable? And that's where Dr. Houghton has coined, you know, guidance for us as a department to ensure that it always meets the 5 A's. And he's going to talk a little bit about those 5 A's in the next slide. But that is a foundational element. As we're designing and ideating, it really does help keep us on track. And then what does transformation look like? So all of this upfront data collection and ideation and innovative thought process, we truly have to ensure that we have, and that we truly install, and we don't just implement.
Yeah, if you go to the next slide, Charles, I'll talk a little bit about, they're not really my 5 A's. In fact, there's been work done in the social space for almost 50 years about at least variations in this 5A theme. So I had a former life as an epidemiologist. Right after college, I got a master's in public health and epidemiology at Emory in Atlanta, and I had a terrific opportunity to work at the CDC and the World Health Organization before I figured out that some of the folks having the most fun were the ones that went to medical school, and I did that next. But while I was at the CDC and the WHO, we worked on terrific projects, things like maternal and child health and infant mortality and clean water. And one of my mentors always talked about the 5 A's. And when you're in a global health environment with resource scarcity and really significant financial strain, what you are able to create for a population boiled down to the individual who's going to use it matters. And it matters on whether or not it's appropriate, it's available, it's accessible, it's affordable, and it's acceptable, right? So you can think about this in a third world environment on whether or not you're going to build a well in an important part of a dry area of your territory. But if it's not the appropriate solution and it's not available when they need the water and it's not accessible to the general population, and then ultimately if it's too expensive and if the folks don't want it, you're going to fail. You'll fail at any level of these days. And so it was interesting, sort of in my own, probably, I was a little slow on the uptake to realize what a terrific tool this is for telemedicine. And it's interesting to take something as rudimentary as nutrition across the globe and expand it to something that is so perceptive or perceived as high tech in what we do in technology. But hear me out on this, right? So if I am going to create a new program, let's say I'm a Parkinson's physician now, and let's say I want to bring an opportunity to have my patients be seen at home with simultaneous and seamless synchronous audio-video technology. First and foremost, is that appropriate to do for Parkinson's disease? Right? Will that provide a quality of care that my Parkinson's patients and families will appreciate? Is it going to be at a time when it's appropriate for them to do it? We said yes. And so then we went to the next one. Well, how available is it going to be? Is it going to be Dr. Houghton at 2 o'clock in the morning? Not very often. But it may be an opportunity for us to have weekend hours. That's a lot easier to accomplish both for the doc in a virtual world and for a patient, particularly a patient who might need a son or a daughter who's a primary caregiver because they're aging in place. How accessible should it be? You know, the technology, particularly with great partners like Tyto and Vidyo, is so seamless. This isn't like your parents or grandparents trying to figure out how to program the clock on their VCR. I don't think anyone ever figured out how to program the clock on their VCR. This is one-touch technology that my father-in-law can handle seamlessly. And so now that we've got access, and now that we've got a community that has an increasing access to Wi-Fi, and we've got technology and tools that run on lower bandwidth, yeah, we've been able to answer that accessibility question. Well, how do we make it affordable? Well, and that's not just for the patient. That's affordable for the providers. And so again, during our pandemic, we learned a lot about some of the changes that allow for affordability. But even going forward, what if some of these codes get reduced? Can a hospital system, particularly if we're in a risk-based environment and we're focused on value rather than volume, I think there's a lot of affordability that everyone can realize to be able to keep somebody with a chronic disease like hypertension or diabetes or Parkinson's or Alzheimer's away from the emergency room. And then lastly, is it acceptable? Do we build all these things and nobody wants it? I think one of and we'll talk a little bit about the Gartner hype cycle in a minute, but there may be some people on the phone who remember the Apple Newton. The Apple Newton was a great program design built by Apple. It was appropriate. It was easy to use. It was handheld. It was the first opportunity to have text that could be read. It was easily accessible. It was available. It was too expensive, so it wasn't affordable, and ultimately it wasn't accepted by anybody. So it got shelved, and then they invented the iPhone on the back of the Apple Newton 10 years later. And so the reality is these 5 A's, whether you're using them in your own practice, whether you're using them with your own team on a project, small or large, I would encourage all of you to think about using the 5 A's. I found it to be pretty helpful, and I know that my team does too. If you'll go to the next slide, Charles, I think Jen's going to talk a little bit about our example of how we use the TytoCare clinics. You heard earlier about the way that we rolled them out quickly into our urgent care environment, but then we needed to optimize and create sustainability. So she's going to talk about that now in a couple other programs over the next couple of slides.
Great. So, Dr. Houghton, you should not have admitted they were not your 5 A's to me. No. So, you know, with all of these concepts and thought processes in mind, we had great success within our urgent care clinics. We had great success leveraging our TytoCare clinics for triage of virtual care to help us with infection control workflows. But as time evolved and that second round of second pain points came through and some staffing challenges came up, along with our patients coming back into the urgent care clinics, we had a whole new set of pain points and urgent care 2.0 to address. And this time it was a little bit more fun because with the rapid adoption, we had all of our providers and all of our clinicians essentially from a telehealth perspective go from novice to expert within a few months. So this really allowed us to foster and ideate some ideas. And one of the things that came out of that was how would we transition to sustainability and continue to leverage the TytoCare clinics that were there. So some of the pain points that our providers and our patients were having is as they were coming back into the urgent care clinics, we still had that disparate workload going on. We still had some clinics that were understaffed and some clinics that had a large patient load. And as you can imagine, a provider pain point would be, well, if I'm staffing the urgent care clinic and in the New Orleans area, I'm going to have patients that walk in a half hour before our urgent care clinic closes, and I'm going to get stuck here for hours, where my colleague out, in another area may be sitting there with nothing to do. So how do we load balance that? How do we offer our patients creative opportunities in this situation? And, through working with our providers, identifying appropriate clinical criteria, you'll hear me say that a lot. A lot of our success is founded on working with our providers to identify the appropriate clinical criteria. We were able to offer options to our patients that says, it's great, we've checked you in. We also have this option of having a virtual visit, and that virtual visit can be completed. Our wait time on that is only 5 minutes, and if you need any appropriate testing or you still need support from us, that we're here. And that really went over well. It was a big satisfier for our patients. It was able to reduce their wait times. We were able to load balance physician workload across our urgent cares, but it also continued to expose our patients to virtual care for buy-in. And even through all this, even through all the visit volume that we have during COVID and adoption into virtual care, there are still those patient populations that are hesitant. And the data and the research that we're still finding is to convert that population, they really want to hear from their providers that this is okay and that this is a good experience and that we can care for you. And what better way to do that is to offer that and facilitate that through our own care and our own practices. Charles, you want to go to the next slide? So we couldn't have more innovation in urgent care without also being able to support our hospital medicine providers. So again, in that thought process, we were still having pain points in looking at our staffing across the system. Our hospital medicine team really worked very hard to think about how we would use telehealth as the equalizer for them across our system. And they designed a program where patients would be admitted to the hospital medicine service, have an initial on-hand assessment from a hospital medicine provider, and if they met the criteria, that patient could be then transitioned to virtual service. And what that would mean is that patient then would continually be followed virtually through the virtual provider, which we loosely use the term bunkered provider, but it was a provider in a central location that could support hospital medicine patients across our system that were appropriate to be on virtual service and offset the workload of the provider staffing that had to be at the bedside and then centralize to patients that were appropriate for virtual service. One of the keys to success in this program was evaluation of the clinical criteria. So we tracked very closely, and this graph on the upper left-hand corner really shows the amount of patients that we had on virtual service, and at any point that they became inappropriate for virtual service, we dropped them off virtual service and put them back to traditional in-person care. And that really helped us take a step back and evaluate to say what patients were appropriate, what patients were not, and then we were able to show over a 4-month period the refinement in our process and the decrease in patients that were dropped off of service. What we also saw alongside of this was increased provider satisfaction and increased patient satisfaction. It allowed the patients on virtual service a few things. One, during COVID, we did have COVID patients on virtual service. It actually gave them an experience that was more humanizing. So everybody was walking into the rooms, they were completely geared up in PPE, and it looked like and it made them feel like something out of a horror movie. And this allowed them to have an interaction with their provider that was more normal. They were in normal gear, their provider was in normal gear, they were able to converse and have a conversation and talk about their care, not behind all of the PPE. It also allowed them to have more frequent touches with their providers. So those virtual providers would have the ability to check in on those patients at the end of the day or follow back through, and actually communicate directly with them, not through a messenger, not through a resident, or not through anybody else. They got more frequent touches from their attending provider because we had the video access into those rooms and those patients were on virtual service. this, this is truly one of those models that also, again, in breaking our fixedness, this isn't just about being able to provide access into the rural communities where they don't have it. It's about us being able to maximize our efficiencies to be able to serve more in those communities as well. So it's taking a step back in that link and in that chain and really breaking some of those, some of the ways that our operators used to think about telehealth. And then, Charles, if you want to go to the next one. Nothing's fun in Louisiana without a active Gulf, without the activity of the Gulf and the tropics. And along with the pandemic, we've had a very active season. And so we were able to immediately take some of these concepts and apply them to disaster relief. But we applied them, again, in a different lens. So we had the experience with having telehealth be the equalizer. And in this scenario, and in our scenario in Lake Charles, it wasn't necessarily that the patients weren't there. It's that when our providers evacuated, they weren't ready to come back into the area, but our patients still needed care. So we took the approach where we took our mobile Tyto clinics. We were able to place them in the community and in some of our clinics and provide, whether our patients needed an internet access point or a device that they needed to do a virtual visit on, we gave them and facilitated their opportunity to have that, and then our providers could make connections and still care for their patients in their community, which was a huge satisfier. One of the things that we always talk about in our disaster planning is that, when the power goes out, you do lose internet and connectivity. So that was part of our planning of our providers, leaving the area to ensure that they could still connect with their patients. Where we came in from the disaster relief was providing that connection for the patients. So getting through some of the examples of where we were and some of our successes and, highlighting those 3 innovative programs that kind of came out of, multiple innovative programs and specifically the last 3 that came out of some of our pandemic response. If there is a graph that keeps me up at night, it's not the graph of the success that tells us about our virtual visit volume, and I am extremely thrilled and excited that we're projected to be able to have 300,000 visits by the end of the year, and that graph looks wonderful and beautiful. But the graph that keeps me up at night is probably this one. And this is the one that says we cannot rest on our laurels. We are not through change management. And this is that Gartner hype cycle. So we had, what worked in crisis, how is that going to continue to work for us through sustainability and optimization? We are not, as I think through this, we're not through that trough of disillusionment yet. We, had a crisis. We implemented a lot of protocols, and we had great buy-in. We need to be thinking what met the need in crisis mode. Is that still going to meet the need as we figure out where we're going to plateau and where virtual care is going to go? And so we want to ensure that we're continuing to think about those pain points. We're continuing to answer the needs of the pain points of all of our customers and where we really, and what success really looks like for us and where we want that plateau line to be. And I'd like to see it high, so that's probably why it keeps me up at night as I'm thinking about this and all the optimization and change management work that we still have to do as we keep moving forward. Some of the things I think about through our optimization is we did a really good job of ensuring that we instituted policies, protocols, and standardization across the board, but it didn't come without workflow variability. And as Dr. Houghton described, during that crisis, or even now as everybody is used to this, the tolerance for workflow variability, the tolerance for, now we're back in that mode of we want it to be easy to use. We wanted to, we wanted to meet the needs. We want it to be desirable and feasible. How do we continue to decrease that workflow variability? Continue to make it easy and ensure a path with little technical failure so that plateau of productivity ends up where we want it. And then alongside ensuring that the reimbursement follows in the same way that we had when we broke down all those barriers at the beginning. Charles, do you want to go on to the next one?
Great, I'll pick it up here, Jen. And so, this is our current story. I mean, this is what we were able to accomplish. It was not easy. Some of it was the same successes, frankly, that a lot of hospital systems have seen because of the the necessity is the mother of invention, if you will. But to piggyback on Jen's comment on the hype cycle, a lot of our peak again was brought on because of necessity, and as we've settled, as we've ended up doing perhaps fewer visits in the ambulatory space. Doug asked a great question in the sidebar earlier about sort of this rapid change from 60% to 20%. Well, part of that, if you look at how our growth was, our totals were still higher overall. So we opened up the clinics again. It was felt to be safe again. And so we're always going to have this sort of dual pressure. We've got our foot in two canoes about how do we continue to make patients experience healthcare the way that they want it in bricks and mortar and the way that they want it virtually. And I think the real secret sauce here is the ways that we can marry those two ideas. So in our consumer-driven economy, I use a lot of Instacart now, but that doesn't mean I never go to Winn-Dixie or Rouse's in our community. So it's an and. I think this is exactly what our patients want. This is what our providers want. We have a lot of docs who will say they'll go back to bricks and mortar, and that was sort of the any port in a storm solution. We have others who have said, sign me up. If I never have to get out of my pajamas again, I won't. But the vast majority of us are going to live in two worlds. And I think our ability to get beyond the trough, ride that slope, which we're riding right now up, to reach another plateau. And what does that plateau look like? Is it 20% of your office visits are virtual? Is it 50% of behavioral health is virtual? Is it 5% of surgical? And you realize that's great for pre and post bundled analyses. I think it's going to be different everywhere. But if we can always sort of focus on, as Jen said earlier, solving for a problem that is brought to you, to any of us, by a clinical need from a patient or a clinical need from a provider, we're always going to be in a good position to be able to solve for that. And this pandemic has given all of us the ability to really learn to be quick on our feet. And the reality is there's things that we would do exactly the same, and I'm sure there's people in the audience who are as comfortable as I am to admit that there are things that we would have done differently. And being able to learn from all these experiences really puts us in a better place to accelerate what really virtual health looks like. And so with that, we'll go to the last slide, Charles, and just leave that up in the background. This is the way that we feel we have come, and this is where we're going. And so I think you heard, hopefully from me and from Jen today, that the pandemic allowed us to practice in this space, but the reality is, in order for us to continue to be successful, we need to optimize, we need to maintain sustainability. Jen, you want to take us home with some of your final thoughts?
Absolutely. So, for our folks, if I think about where our department focuses, it's going to focus on continuing through the change management. It's going to continue through optimizations and really breaking fixedness. So often in the past, I've heard for years in the telehealth space, we have to create parity, or our telehealth visits have to be, as good or better than in person, and really breaking that fixedness to reinvent the patient experience and make it something completely different and something something better. And that's where we really need to go. Now that we have tons of clinicians and providers and healthcare workers that have gone from novice to expert, it's that ideal situation for all the ideation to happen and for us to truly be able to break that fixedness. And then for us to also a little bit get back to our roots and say, there was secret sauce. There is secret sauce to telehealth, and let's get back and reinvigorate some of those concepts and ensure that we don't lose sight of what's in the secret sauce as we're ideating and making things better.
Thanks, Jen and Dr. Houghton, for that engaging content. So in respect to Vidyo, at Vidyo, we have a really deep history of innovation and leadership that has really enabled us to become the world's highest quality interaction platform. Our solutions empower our customers to visually enable any action or idea. We empower systems to collaborate by increasing their effectiveness with purpose-built workflows for healthcare practitioners, and we also provide patients with a really immersive experience to network with their healthcare practitioners and their families. Vidyo is a really deeply embedded solution provided to thousands of patients through Epic MyChart, and is also available through contextual aware linking. Additionally, we have a deeply embedded solution in Cerner and Allscripts, both of which we are in active discussions with to broaden the capacities of their programs. And leveraging the power of virtual care, we have partnered with other leaders in our ecosystem to expand the delivery of healthcare to patients regardless of their location. For example, as you may remember from our last webinar, was Enghouse, who provided us with powerful capabilities in respect to insights and metrics reporting. Now, we were happy to open the floor to questions. I saw that actually Dr. Houghton was doing a great job of answering some of the questions in the chat. I really thank you for that as well. And if anyone has additional questions, please feel to enter in the chat, and we can answer them as they come in.
I'm still on the job, Charles.
Oh, great.
You make our job easy. If I can't sit and hear myself talk, I like to hear myself tap.
Great. Okay, so let's see here. Oh, you actually answered the last one. Thanks, Dr. Houghton. Great.
But I can take a few of them. I mean, I think
sure.
There's been some good questions out there about the use cases for Tyto from our perspective, and I'll let David comment on it as well with his expertise. Greg had a good question. Agreed. In our presentation, we talked a lot about the ways that we were able to use the Tyto Clinic, and not only in our urgent care space, but we distribute, I can't remember if we had this up there, but more than 100 employers have signed up since the onset of this. So for 2020, certainly more than we anticipated, because they realized this is a great back-to-work option for them. Schools are the same way. But we've also distributed hundreds of our Tyto home kits to our patients. They have an opportunity to purchase those as part of their medical equipment benefits through their insurance products. They can pick them up at our pharmacies. We have these things called O-bars, which the O for Ochsner. It's sort of like a take on the Genius Bar at Apple, and that's another place where they get them. So we've really seen a lot of value in multiple environments. David, you want to comment a little bit about where you think the value lies the most between sort of the clinics or the home space?
Yeah, I think at the end of the day, I think it's really around what you're trying to do in terms of use case. I think the idea here is that, we're really trying to empower the physician who's typically accustomed to using the clinical tools in their exam rooms and bridge that gap by bringing that, whether it's into the home or point of care location. So really the possibilities are endless. I think the key differentiator for Tyto is that it is approved to be used by a non-clinically trained individual. So a lot of the use cases and the breadth of what you can use this product for in the home, as well as in places where it's an unmanned kiosk at an employer site, for example, that's the real differentiator of that. I did see a couple of questions come up specifically around the use of the product. There are ways to, again, use this, again, through the VIDYO Connect experience, through the integrated format. And like Vidyo has the CAL experience, Tyto also has a CAL experience as well. So really depending on your use case, there is no one right fit solution all. I think there are multiple solutions that can work for a variety of different use cases. So I think that would be my 2 cents.
Great. Great job, Dr. Houghton. I saw you answered that question with respect to electronic blood capture as well. So great, making our job easier.
Yeah, I'm on it. So Deborah had a good question about what sorts of devices that we use for capturing vital signs. In the real world, when the rubber hits the road, whether it's part of our Ochsner Anywhere Care for urgent care or for patients who are doing virtual visits, a lot of times that's manual and it's easily uploaded. We're an Epic shop, and so you can upload your manual stuff into Epic, and then that goes into the electronic record and a note for the provider. So that's sort of gives the most flexibility. We actually have a program. We have a digital medicine program where patients sign up at the enrollment of an enrolling provider. So your primary care doctor wants your diabetes to be managed as part of our Ochsner Digital Medicine Diabetes program. When that's done, we have products that have been curated and vetted and sync Bluetooth directly into our EMR. So iHealth for blood pressure, for instance, others for diabetes. But we try to be as flexible as possible for what other people have. And then there was a question from Brian about our on-demand. Yeah, Ochsner Anywhere Care, we've been a good partner with American Well for years. We only recently, so initially they have the American Well health group that helps sort of manage from a physician perspective. When we launched off the ground to maintain a 24/7, 50-state strategy, we relied on them a lot in the background, sort of as our bench. Now we use all our own providers on there, but we still utilize them for their tech support and interface and all the other great stuff that American Well provides too.
All right, perfect.
Try to see if there's other ones out there that.
I think I see a question. I think we're answering a lot. I see one. Do we use hardwired cameras in inpatient rooms or mobile carts? The answer to that is both, yes and yes. So you know, and some of that goes back to the design principles that we talked about, is understanding the pain points. And our design principles are always ease of use for the provider, ease of use for the patient, and good for Ochsner and the organization from a business perspective. So, you know, whether it's a hardwired room or a mobile cart or an iPad or an endpoint, or like Dr. Houghton said, what we use for on-demand versus not on-demand, it really does focus around those design principles and our partnerships. We do use hardwired inpatient room cameras and mobile carts. What we learned through the pandemic and kind of what we're pushing through is that inpatient hardwired experience from a hospital perspective really did prove the best experience for the patients and the providers together. It really allowed us to have an on-demand access into every room, so it was very easy for our physician providers to go. We have a campus that's completely hardwired. It allowed an on-demand approach for all of our providers to go into the Kenner campus very easily and see their patients and see their patients. It also allowed our nurses to do that, our social workers to do that, our pharmacists to do that, our diabetes educators to do that, and truly that on-demand experience into the room that didn't require a telepresenter truly met all of the pain points. So that is one thing that we're looking at in the future on how to expand those in-room solutions.
I'll tell a quick story about our mobile devices. So, you know, right at the heat of everything for our community, and some of you may remember this, we had lots of iPads because we utilize them in different ways across our system. But you couldn't find an iPad stand anywhere globally without waiting for weeks and weeks for it to be delivered on Amazon. Same thing for Logitech cameras, and so I think they were bought up by every elementary and high school kid in the country at the same time that every hospital was trying to buy them. So we had a really fun exercise in design thinking where we have a 3D printing operation here within the hospital that we utilize with AR and VR and some other cool stuff. But we essentially designed our own iPad stands that would attach, that we 3D printed, was approved by hospital inspection, that would attach with zip ties to an IV pole, and it worked great.
Great. Perfect. I see. It looks like the other questions that are coming in are being answered. Yeah, thanks for. I think it looks like we're right on time. Want to really thank everyone for the engaging content today. I really appreciate the engaging questions from the customers who have attended today as well. Today concludes today's webinar. And just a reminder, as noted in the chat, we will send out a recording for the webinar for everyone to review. And feel free to contact our teams as well. Thank you, and talk to you next time.
Thanks, everybody.
Thank you, everybody.